employees, they turned to contractual nursing staff. Lauren had requested an extra 13.0 million SGF in anticipation for that contractual nursing staff. Additionally, there was an adjustment for its food service contract. It had received an estimate from the individual it contracts to provide food for the agency for the patients there, which was significantly higher than what they had anticipated. The second bullet there is for osawatomie. There was overall there wasn't much of a difference in osawatomie. The major thing I'd like to point out was that there was about a $2.4 million swap in expenditure categories, mainly again for switching kind of the salary and wages to contractual service, sort of representing that anticipation for needing the adequate coverage and having to utilize contractual service nursing staff for those. There at the bottom of page 2, you can see that the governor recommends $120.1 million, including 95.8 million SGF. It's a decrease of 14.2 million SGF below what the agencies requested. And that first bullet there at the bottom of page 2 really sort of explains the bulk of it, is the governor not recommending the agency's Larna's supplemental request for that 13 million for contractual service nursing staff, as well as in between the time that the agency submitted its budget and the time that the governor released hers, the food service contract was they had a revised estimate, which was a little bit lower, which allowed for some savings. Additionally, there on page 3, you can see the second bullet, the Larned State Hospital had requested an additional supplemental regarding safety and security FTEs, which the governor did not recommend, and I'll go into that in a little bit more depth here in a moment. And then there was a supplemental request regarding a reappropriation lapse at osawatomie. So as you heard yesterday, there's Parsons has a sexual predator treatment program reintegration unit in its campus. Osawatomie also has a similar unit on its. Traditionally, there was the funding for that was in Larned's budget. And I believe it was 19 that was shifted to osawatomie. And in that bill, there was left out language to reappropriate funds for that account. So subsequently this year, those funds lapsed, and the agency had sort of requested those funds back from the governor's office, which the governor didn't include in her recommendation. I would note then on page 3, that middle portion begins 2023. The agencies request a revised estimate of $144.9 million, including 123.5 SGF for expenditures. For Larned, that amounts to $93.2 million, including 83.8 million SGF, while osawatomie is $51.8 million and 39.7 SGF. As an overall expenditures increase of $10.6 million from the agency's revised estimate. The main point there I'd like to point out is there were several enhancement requests, which I'll go into a little bit more detail here in a moment, regarding the sexual predator treatment program. Larned had indicated that they are anticipating growth in that program, had asked for additional staff and additional units for that program. Additionally, that last bullet on page 3, there was a request to increase the staff for the psychiatric services program. That would be the individuals. So at Larned, there's 3 sort of programs: sexual predator treatment program, state security program, and then the psychiatric services program. And those are the individuals who are there usually on civil commitment, not there for any court reasons. On page 4, the last bullet there at the top is some moratorium-related increases related to osawatomie's budget, mainly a request for a social detox staffing and staffing for the building once it is completed. There at the middle, you can see the governor's recommendation was 124.8 million, including 103.3 million SGF, decrease of 20.2 million. This is primarily due to not recommending those enhancement requests with LARNED, as well as for both just continuation of that 13.8 million for the contractual service nursing staff, as well as the denial of those SPTP funding. I will note that the governor did accept Osawatomie's enhancement requests for those moratorium related, as well as some operational and upgrade costs at Larned State Hospital. I would note on page 5, that very first bullet you'll see is regarding salary increases, very similar to yesterday with the IDD facilities. There was 2 executive directives during the summer to increase the pay for those kind of direct care support workers. Originally, just as with the IDD hospitals for 22, there was some funding that was found to cover those costs, but in 21, there needed to be some additional funding for Osawatomie and Larned. Larned had included it as a supplemental, and then subsequently Osawatomie had that added in the governor's recommendation.
Matthew, can you move to page 8 and probably do more of a highlight, because I don't think we're going to be able to get through everything in time.
Certainly. I would just note,
Request, that's...
Yep. So on page 8, you'll see the more detailed version of those shifts. Looking at that table, you can see the supplemental enhancements request. I would just point out really page 15 is where those supplemental enhancement requests are in more detail. And you can see the tables there of what the agency requested and then what the governor recommended. So page 15 is going to be that SBTP related requests for Larned. You can see in 22, there were the request for additional safety and security FTEs, that roughly $550,000 that wasn't included in the governor's recommendation. And then you can see the 23 requests as well. You can see those additional enhancements that were requested and that were not included in the governor's recommendation. And the same for on page 16, you see those operational costs for Larned. Again, on 22, you can see that contractual nursing staff that's under the agency's request was requested for both years, denied both years. And then you can see that adjustment for the food service increase. And then you can see in 23, the enhancement requests, both for those executive directive increases. There was the request for upgrading the phone systems that were included, and the SSP security upgrades. Those are for ligature-resistant furniture, as well as, I believe, some, I think that was the bulk of it, is maybe some security upgrades. There's a shift for paying for some of that with SIBF, the State Institutions Building Fund, which is why the GovRec is slightly lower. And then on page 18 is Osawatomie's requests. You can see in 22, there was that supplemental for $53,000 for reappropriations, but then in 23, those are those 2 requests related to the moratorium lifting that the governor included in her budget analyses. So those would be any of those shifts on those that FY22 more detailed on page 8 through 10 are really those enhancement and supplemental requests, and the same for the 23 analysis on 12 to 14. Just most of that detail is going to be in those gray boxes for you. The remainder of the budget analysis is just that more in-depth on Larned specifically, going into specifics about the hospital, about the programs on it, census information, and then kind of that salary and wages and category of expenditures table for both hospitals. I would just note on page 28 is sort of the capital improvements. Most of the capital improvements for the state hospitals are included in KDAD's budget. However, every once in a while, as you can see, there's some funds budgeted for small repair work that are included in the agency's budgets. but those are going to be for patching up roads, sidewalks, those small sort of projects. The bulk of those capital improvements will appear in KDAD's budget, and then they'll be heard before Joint Building Committee tomorrow. But with that, unless there's any specific questions, that would conclude my.
Questions for Matthew? All right, thank you, Matthew. Next, we'll move on to Secretary Howard.
Thank you, Madam Chair. Secretary Howard with KDADS. We'll do the same thing as yesterday. I'll have Scott Bruner start the presentation. We also have with us today Mike Dixon, who was here yesterday. He's here today in his role as the acting superintendent at Osawatomie. As you can see, he wears, I think, 3 different hats for us right now. And then Lisa Dittman, our superintendent at Larned State Hospital, is also with us today. So I'll have Scott start the presentation, Senator. Thank you.
Welcome, Scott.
Thank you, Madam Chair. Scott Bruner, I'm the Deputy Secretary for Hospitals and Facilities. We've got a slide deck or slide presentation that'll look kind of similar to what you saw yesterday. I'll endeavor to not repeat too much of what I told you about yesterday, but on the first couple of slides, 2 and 3, we did want to describe the programs at Osawatomie State Hospital and Larned State Hospital. Just to remind the committee, at Osawatomie, there are 2 separate hospitals that operate on the campus. There's Osawatomie State Hospital and Adair Acute Care, which is the certified component of that hospital. You'll see both of those components in different parts of the budget. For your purposes, you see it as one budget, but there are 2 separate hospitals operating. The other is at Larned State Hospital. There are really 3 programs that operate, and Matthew mentioned this. There's the State Psychiatric Hospital, Psychiatric Services Program, which is the care and treatment arm of the hospital that serves people in mental health crisis. There's the State Security Hospital, which takes folks that are defendants that are remanded to Larned for competency evaluation or restoration. And then the Sexual Predator Treatment Program, which you talked a little bit about yesterday, but the inpatient component of that program, the largest component, is on the Larned campus along with one of the reintegration facilities. Just to, again, not to confuse you too much or put too much information in front of you, but just that these different moving parts are all part of the system. On slide 4, like yesterday, tried to capture both the budgeted number of beds for each of those components, or I think it captured all of those components, and what our average census has been through this fiscal year, through the 1st of January. And maybe just a couple of comments or things that I would point out on the Adair acute care side. It's budgeted for 60 beds. That assumes that every room we have on that in that facility would be double bunked or have 2 patients in there. With COVID, we haven't been able to do that. With the funding that we've received from the legislature in the past couple of years to do some of the remodeling to expand bed capacity, the vision long-term is to have those rooms be single occupancy. So we've been effectively operating that way for the last 18 or 20 months. So that's why the census is down around 32 as opposed to the 60. And then the state security program at Larned is budgeted for 140, and it's also been held at a lower level, somewhat related to COVID, to maintain an isolation space because of the 3 separate programs and because their people are at Larned for different legal reasons. We can't mix the populations for isolation and quarantine purposes for COVID. So that's meant we had to create an isolation unit in each program, which impacted bed capacity. We've also had, and you'll hear more about staffing as the superintendents testify, just we can't staff the units to keep them at a higher capacity. So that's why that average is quite a bit off the budgeted level. On the next slide is our turnover and vacancy rates for both of the hospitals, and we do this at a higher level of all positions. You can see that those rates are comparable between the 2 hospitals, but significantly higher than they were at Parsons and KNI that you saw yesterday. And we can talk more about that as you have questions. Then I think the last part I'd just comment on, moving forward to slide number 9, just the kind of overall impacts in the system. The pay plan items we talked about yesterday, both the direct care salary increase that happened over the summer did impact all 4 hospitals. There wasn't as much to do at Larned as there was at Osawatomie, so you'll see the dollar impact there. There's the 5% pay plan that's in. the governor's budget, and Matthew appropriately corrected me yesterday. That budget doesn't show up in the hospital budgets as an item. It doesn't show up in the KDAD's budget as an item. It's one dollar amount for the whole state budget and the governor's recommendation. So, and that'll get distributed depending on the legislature's recommendation about that as a budget item. On the next page is the 24/7 pay plan. The only comment, it's kind of the same song and dance as yesterday. The one difference is that for both Larned and Osawatomie, they were, because their vacancy rates are over that 25% threshold at both hospitals, they're getting that fourth differential. That's $2.50, and that impacts every hourly employee on both campuses. That wasn't true for Parsons and KNI. And then just the last couple of recommendations that'll show up in the KDAD's budget, but do impact kind of the operations of the hospitals. Starting on slide 12, the governor did recommend $15 million for us to start the planning, design, and potentially construction-related work to add 50 beds somewhere else in the state, not Larned or Osawatomie, to provide some additional inpatient capacity in the state for both competency or for forensic cases and for folks that are there in mental health crisis or need a commitment for mental health crisis purposes. And we can talk some more about that. There's also some additional funding, $2.8 million, to expand our use of mobile competency. One of our issues at Larned is the backlog of getting people in to have their competency reviewed and then restored to have criminal processes continue. We've had some success in using a vendor that works with us at Larned to do that work in jails where the defendants are, primarily doing forensic evaluations. So the governor's added some funding so that we can expand the use of that either through our contractor, maybe identifying another contractor, working with community mental health centers, other willing partners that would help us expand the reach of that to do those evaluations where people are as opposed to bringing them to Larned. And then on slide 13, just the capital improvements that Matthew mentioned. There's an additional $8.1 million of state institutions building fund that the governor added in 2023 that takes all of in our capital plan, we identify first priority and then second priority projects for funding. That $8 million lets us clear the whole list through the second priority of projects, including some of the raising projects for buildings that are not useful. I don't want to say derelict, but that's probably the best word to use. Buildings that we need to raise that we've raised that with the committee a couple of times over the last few years. But that's a significant increase in our capital improvements budget, would clear a lot of the backlog of projects that we've had on the list for a while. But I'm happy to talk about that today or with the KDAD's budget whenever you think it's appropriate. But those are things that impact the hospitals and wanted to raise them today. That's all that I was going to walk you through today. I'm happy to turn it over to Superintendent Dittman to talk about Larned or take some questions if you have any for me right now.
On that mobile competency, is that cost, is that FTE cost? Or, I mean, because it says here to community mental health centers, I mean, so we already may have the bricks and mortar out there?
The model is that we would do the competency evaluation for the defendant while they're in the jail. So in terms of where the person is, they're an inmate, they're in a county jail or city jail. The cost would be to have the therapist, psychiatrist, psychologist go in and do the evaluation review and write the report to the court. So I'd probably characterize it more as staffing cost, or as we use a contractor to do that, we pass that through the contract.
So they have the ability, the community mental health centers, to do this test?
Some do, yes. Some currently do it in partnership with their courts and jails. They do the competency evaluations for the court system. Okay. Part of this would be to expand the role. We have a partnership with Vallejo here in Shawnee County with the Shawnee County Jail, where they're actually doing competency restoration in the jail itself. So we don't need to bring, I think there's 4 people in the pilot to Larned. We could use some of this money to expand that where it would work, where there's a willing partnership between the
So help me
mental health center and jail.
understand then, why does, and maybe there's a whole different situation going on, why does Sedgwick County, it seems like, has to drive to Larned? Or
It's a good question. We've talked, and Lisa may want to, because they've had some conversations with Sedgwick County as well, and they've done some different partnerships to kind of expedite the process for Sedgwick County. She might have a few more details about that, but a lot of it is we've got to find a willing partnership. Not every jail wants to have somebody receiving mental health treatment in the jail for restoration purposes. I don't have the capacity, don't have the medical support to do it. So it wouldn't work everywhere, but we are looking for willing partners. And with this funding, we think we can expand some of those partnerships to do it. And it might include Sedgwick County.
largest jail in the state.
Yep.
So, any other questions for Scott before we move on? Okay.
I'm happy to come back later.
All right, thank
Turn it
you.
over to Superintendent Dittman.
All right. Welcome
Good afternoon.
to the East Coast.
Thank you, Madam Chair and committee members. My name is Lisa Dittman. I'm the superintendent for Larned State Hospital. And as mentioned earlier, Larned State Hospital does operate 3 distinctly different programs: the Psychiatric Services Program, the State Security Program, and the Sexual Predator Treatment Program. And I'll just highlight a few things from each of those programs. The Psychiatric Services Program last year admitted 827 patients and discharged 814. On slide 17, there are 3 graphs there that are related to the wait list. There was a wait list necessary 82 days last year, and on average, there were 12 individuals on the wait list. And the average wait time for those individuals was 31 hours. The next slide shows admissions to the program by county, and the largest counties that admitted to Psychiatric Services Program were Reno, Saline, and Ellis. The second program at Larned is the State Security Program. This program serves the adult males and females that are charged with felony crimes, and they're referred from the district courts across the state. In addition, this program also houses the Security Behavior Unit, which is a 20-bed unit. Then on the next slide, actually the next 2 slides, you will see graphs that are related to the wait list on the State Security Program. The first is the total number of defendants that are on the wait list, and then the next 2 graphs are the average length of time on the wait list for males and then also for females. Looking at slide number 22, it shows where the highest number of admissions for the State Security Program come from. And just like you just mentioned, Sedgwick County is the highest, with Shawnee County and then Wyandotte County. Going to slide 23, the third program at Larned is the Sexual Predator Treatment Program. It is our largest program. These are individuals that are admitted through the Sexually Violent Predator Act. Moving on to slide 25, there are a total of 247 residents in the inpatient program, 22 residents that are currently in the reintegration facilities, and those were the facilities that were talked about earlier, and then 17 individuals that are on conditional release. Staffing at Larned continues to be a struggle. We did implement the governor's 24/7 pay plan. We are recruiting very heavily on Facebook and through other social media. We've participated in a few in-person and mostly virtual job fairs. We produce commercials, and we're also using digital marketing. We're hiring full-time employees as best we can. It is very difficult, and we do rely heavily upon agency RNs, LPNs, as well as CNAs. Then if you move to slide number 28.
I know it looks like I'm in a hurry, but you're going so fast.
No, well,
Sounds like my
sorry.
budget review on fee agencies.
Sorry.
So are you able to participate in the traveling nurse, or is that a whole different category?
Traveling, we have agencies we work with, and those are traveling nurses. They travel from other states, other countries even, and come here. Yes. Yes. You're welcome. Okay, on slide number 28, we have been focusing our efforts on mobile competency to address the wait list with the district court referrals. We are working with district courts to see if we can do some of those evaluations through mobile competency, as Scott talked about earlier. And excuse me, we have been able to establish one position that works solely with that wait list. That person hasn't been on very long, but that's the goal of that, is to try to work through that wait list just as quickly as we can and work with those courts and the jails. We have completed mobile competency evaluations in 21 counties so far, and we currently have a pilot project with Shawnee County providing competency restoration service in the jail, and we also have been in communication with Sedgwick County as well as Douglas counties to talk about similar projects there. And this is our first actual attempt to do competency restoration. The other mobile competency has actually been evaluations, so it's a little bit different to do the restoration versus the evaluations. On slide number 29, it shows the types of evaluations that we've completed by mobile competency, so those are listed out there. On slide number 30, it shows the counties where mobile competency has been completed. Okay, on slide number 31, I'm talking about a few initiatives. We have worked to try to expand telemedicine on campus. We are purchasing telemedicine equipment, and we also established additional medical and dental clinics for our sexual predator population to try to be able to serve them on the buildings where they reside versus having to transfer them off campus or across the campus. And we also have expanded physical therapy in the same manner, trying to serve the individuals where they are. And then slide number 32, it has a list of security enhancements. Those are also listed in the governor's budget enhancement. And then talking about significant changes in our budget, those are listed in some of the later slides there for Larned. Slides 35 and 36, they speak to the enhancements that are in the governor's budget, which Matt talked about earlier, so I don't want to repeat that. And with that, I'll stop there and stand for questions.
Okay, back to my question that I had for Scott. Why is it that we don't have, it appears to me that our sheriff is always having to drive to Larned, and why do we not have somebody just stationed in Sedgwick County?
Yeah, Sedgwick County, we've actually had recent conversations with them because what we want to do is we want to mirror what we've done in Shawnee County with taking an evaluator actually into the jail. Most of our mobile competency has been by televideo, and we find with the wait list, the ones that are on there are those that need competency restoration, and so that's the majority of those individuals. It's difficult to do that by televideo, and we found more success going and actually seeing them face to face and trying to do it in a small group setting. So our goal is to expand that and to be able to go into Sedgwick County, Douglas County, Shawnee County, those larger counties where we see the populations. And so I anticipate that that is what we will be doing. In Shawnee County, we had 4 individuals that were in the group. 2 of them were found competent and have moved on, and then there's 2 that are still there, and we're getting ready to add more individuals. So we have been in conversations with them. There is a criteria that the person has to meet because they have to be able to do that competency. If it's someone that is not able to sit in front of the person, they're not able, maybe they need medication, something like that, they may have to come into Larned. So there is a criteria. We do work with the mental health center and also with the jail to talk about each individual person to see if they can qualify to have it done by mobile competency.
Okay, so back to that 2.8 million enhancement. I'm just trying to figure out what is bricks and mortar and what is human resources.
In my opinion, I mean, and correct me if I'm wrong, Scott, it wouldn't be bricks and mortar. It would be for those evaluators to go out, to go into the jails, to hire people, to work with mental health centers, because mental health centers, they often know these people. They've been in the community. They're familiar with them, to work with them, to also try to assist in attaining that competency quicker.
Thank you. Mm-hmm. Any other questions? Senator Petty, and I'll get you, Senator Kirsten.
On the funding for agency nursing staff, so what does it turn out to cost you on an average, daily average, or hourly average, I guess you should be asking, for a temp nurse?
Currently, and I may look back at Stacy, our CFO, my understanding is the nurses, Stacy, are 190? Do you want her to step up to?
Yeah, come to the podium and identify yourself, please.
Good afternoon, Madam Chair and Chair Council. Sorry, I'm Stacy Parr, the CFO at Larned State Hospital. It just depends on what agency that we're able to get. We are struggling with staffing. We're having to bring staff in to cover the unit. We're having to use multiple contracts. An hourly rate for an RN could rate from 185 is the highest. The lowest we found is $77. However, most of the ones that we're able to get to come to Larned are on the high end. Most of the contracts we're using are 185 for an RN, 100 for an LPN, 65 for CNA, which would be equivalent to an MHDD at our facility. We are increasing the number of contract staff that we are seeing on a daily basis. We went from an average of 74 in December. I don't have all the invoicing completed and calculated for January. However, in our last class, we did add an additional 29.
So that, I mean, you gave for several different categories, but since I asked about RNs, so that ranges from 77 to $185 an hour, and it, depending on who you have, who you're contracting with, who has the available staff, and in your situation, it's often towards the higher end. Is that correct?
Yes, because most of the ones that are sending us the staff, and we are seeing where, you know, maybe somebody's working for staff company A, and they talk to somebody and they say, hey, we're making this, and then they decide, well, we don't want to work for A anymore. We're going to go to the higher paying contractor, and we see that at our agency. So we might bring them in, and they might be on one of the lower paying ones, but then all of a sudden they end up moving to the higher paying. So most of ours are making $150 to $185 an hour for an RN.
And then you said last month was this, you said, I think you said a number of 74. Was that 74 that you had to have a day or?
Just over the month.
Over the month, okay, thank you.
Senator Kirshen?
Thank you, Madam Chair. My question, well, the remote question that Senator McGinn asked you about, on the out-of-state piece of it, I've seen 38 out-of-state members. Where are they coming from, and why are they, is there for services, or they know somebody, or we don't have the training where they are? What brings them into our circle here?
Are you talking about the admissions for PSP?
No, there was a list of, they had 38. Turn the page.
Okay. Do you want to answer that?
Give us the page if you found it on 38.
No, that's what the number was.
Oh,
Which program was it on? I'm sorry. Oh, okay. What slide?
It was a list.
Okay, slide number 18. Is that the slide? So those that say out of state would be somebody that could be here visiting somebody traveling through the state, and they got picked up. It's a variety of reasons why people are here. Yeah.
That's quite a few, though.
Yeah.
Another question then, on the sexual predator, that's another, it seems like over half your people are guilty of sexual predator of some kind. 252, I think the number was.
Yeah, 147 inpatient.
What's the average age for those people? Is it middle age or older?
If I have that. The average age is 54.
Really? No, not very many teenagers, in other words.
Well, these would be individuals that have been in prison and served their prison sentence, and this is after their prison sentence, and so some of them maybe have been in prison for a while.
they pretty much don't ever graduate. So I'm thinking of those nursing homes that are becoming available. I seriously think we need to start thinking that direction eventually, because this population is just getting older. Anyway, all right. You finished or not? Okay.
Unless you have
Any other questions?
No, that's it.
Okay.
Thank you.
All right, thanks for coming in today. Mike next, right? Okay. And we have to be out by 1:15, and so just a show of hands of anybody that came in from out of town. I don't want to miss anybody. Anybody outside of 10 miles? You? Are you on, where are you at on the list?
She's with me.
She's with you? Okay, so nobody else drove in from out of town that can't be here if we have to schedule more time. All right, thank you. Well, welcome.
What about me?
Yeah, we're stuck here. All right, good to see you again, Mike.
You too. Thank you, Madam Chair, committee members. I'm Mike Dixon, acting superintendent at Osawatomie at the moment. OSH just celebrated their 155th anniversary at the end of October. We opened up the part of the campus for for the community to come in. We had a 5K. We had some tours of the buildings. We had food trucks. It really was a great experience. Scott was awarded a proclamation that day. So OSH serves 45 counties in Kansas. And as Scott said, we have 2 separate hospitals. We have OSH and then we have Adair. Adair is our acute intense inpatient psychiatric treatment. And then OSH, we do have a lot of the same individuals that are on the AAC side, but we also have criminal court commitments and our dual commits. Slide 41 just looks at the different counties that we serve. As you can see, our highest ones are Sedgwick, Johnson, Wyandotte, and Douglas, and Shawnee. Slide 42 looks at our moratorium waiting list since January 1 of 21. Towards the beginning of 21, our list was a lot higher. That was really relative to COVID. Slide 43 is the OSHA's average wait time in hours per month. We are currently on a downward trend with that also at the beginning of the year was pretty high. Next slide, 44. This is looking at AAC patient days and census. It also looks at the average length of stay, our admissions per year going back to 2019, and our discharges. 45 is the exact same graph, but for the OSH side. 46 is a combination of the 2 hospitals, average length of stay, combining OSH and AAC. Over the last few months, going to slide 47, we've adopted the Franklin-Covey process to make some systematic changes at the hospital. We've created several WIGs, which stands for Wildly Important Goals. And the good thing about the Franklin-Covey process, it really flattens the organization. It's not just our leadership staff making decisions, it's looking at everybody that works with the individual and giving them a voice to make change. Our currently WIGs that we have going right now, we have a Pyxis WIG going, which is a medicine dispensing system that we're in the process of implementing at both Osawatomie and LSH. We're hitting recruitment and retention really hard at the moment. We are, as I talked about yesterday, switching over from CIT at Parsons to CPI. At OSH, we're making a change also. OSH currently, and AAC, currently used CPI, but they didn't train the full 4 days of it. We only train currently the first 2 days. The last 2 days are advanced holds. So to make sure that our staff are safer, I have 10 staff actually going through this week, becoming trainers to train the last 2 days. We did a safety survey over the summer, and we identified quite a few safety issues that the staff felt were present. So we have a safety WIG right now. We're trying to hit safety from all areas. 48 is just a breakdown of what our recruitment and retention subcommittee is looking at. We're looking at advertising, doctor recruitment, education and internships, employee appreciation, recognition, and incentives. We just had in December a staff appreciation week that every day we had something planned all during the week to recognize our staff. Secretary Howard came. We had a recognition ceremony, our first one in several years. Last 2 years we didn't have one because of COVID. And that was received really, really well. And then once again, even with our recruitment and retention, we're looking at safety, making sure our staff feel safe. The big news for Osawatomie on January 3rd, we did lift the moratorium. On a slide coming up, you are going to see that it says that we haven't admitted any voluntary admissions, but we did. The day that we submitted this testimony, we admitted our first voluntary admission. In addition to the moratorium, on January 24th, we re-implemented our social detox program. To make sure that we don't get in a position that we were back several years ago, we have implemented a census management procedure at OSH. So whenever our census is below 85%, we will accept voluntary admissions, and that's separate for AAC and OSH. Today, for instance, OSH is above the 85%, so we're not accepting any voluntary admissions on the OSH side, but AAC is below. So we can accept voluntary admissions on that side. Our social detox programs, that is on our Adair unit, AAC, and we have identified 3 beds. We put 3 beds aside at any time. We can have up to 3 social detox patients. So far, we haven't had any.
Do you ever use the beds for anything else? You can't?
We're going to save them only for social detox.
Okay, and then are they, because they're in the Adair facility, so they're not the ones that we spent, you know, $1 billion on to make sure they have literature, the word I can never say, but I mean, so those beds are just regular, not regular, but they're not as high criteria as the other beds.
They are on Adair, so that is our CMS facility, so I'm not 100% sure.
Well, I'm thinking of we paid for X amount of beds because that's what we could afford. And so I think we still have beds that we could remodel or.
In the process.
So are they those beds? That's what I'm getting at. Or are they the beds that we raised to a higher standard?
I believe that. Yeah.
They are the beds that we raised to a higher standard. Okay. Not that people, yeah, going through detox, I mean, they could have the same challenge as well. Yeah. Right, okay.
And those beds, they're only for 24 hours. Normally, you know, the person comes in, we hold them for 24 hours. If they should present a suicidal ideation going forward, then we could have them screened for admission over to the OSH side or a different bed on Adair.
Okay.
Slide 52 is an update on our remodeling. We're very, very close to having B2 remodeled. It should be finished by March 1st, and then East Biddle will begin. It says on the slide January, it'll be March. We're hopeful to start the remodel within the next 2 or 3 weeks. We're projected to occupy that space in September of 23. Slide 53 is our COVID update. I will say since January 1st, we've had 110 staff test positive for COVID and 63 patients. So as it was at Parsons yesterday, OSH has really been hit pretty hard over the last 6 to 8 weeks. 54 is the different things we're doing to prevent the spread of COVID. And then the last 2 is slides that Scott presented on, so I will stand for questions.
Questions for Mike? So the people going in for detox, I assume those would be locals.
I would think they would be fairly close.
And then the CPI, advance holds,
Yes.
that's for people that are out of control?
Yes. Yeah, we currently have the staff are currently trained for the first 2 days of CPI, which doesn't treat the advanced holds. We do have individuals at OSH that do require safety holds from time to time, and staff do get currently a preliminary training on how to do that. There is an additional 2-day training that we can provide, and that's what we're in the process of implementing. Just additional.
If juvenile detention facilities have this training?
I'm sure they do. CPI is nationally recognized, so I'm not 100% sure, but I would guess that's what they use.
I was just thinking of the incident that happened in Sedgwick County about 6 weeks ago. So that's, if that is a good training program, I'd want to know that, yeah, it's getting used elsewhere in the state, so.
It is a very good training program.
Other questions for Mike? I guess after all the years I've had this, I didn't realize when you said that there's 2 hospitals. Is that for licensing reasons?
It is. CMS has identified that we have the 2 separate hospitals. That's how we reestablished being able to bill for Adair, but not OSH.
Okay, okay. And then Biddle, building, can you send me a picture? And, because I can't remember which one it is.
Sure.
And then I saw somewhere in here that we're actually tearing 2 buildings down. Yes. For 10 years. Thank you. Questions? Okay, Senator Petty.
So what amount of federal, I see here that you did receive $42,613 from the American Rescue Plan to offset the cost of the meritorious service awards. But what other, have you received any federal funds for staffing needs?
I will. Karina, do you know? Is it okay if I call my
That whole
CFO up?
traveling nurses and everything else, all the money that's going out to the private sector, I'm just curious if we're able to capture.
Is it okay if I call my CFO?
Didn't want her to travel all this way and just sit there on the second row.
Good afternoon. I'm Karina Adamson. I'm the CFO and COO of Osawatomie State Hospital. We did receive $450,000 last fiscal year. That was part of the CARES Act. We got phase 1 and phase 3 funding.
And that was used for?
That was used primarily for staffing, offset the cost of hazard pay.
You okay back there? All right, good.
So are you eligible for application for any of the Sparks funds that are?
Try that one. Scott Bruner with KDADS. We could be, there's a state effort to identify Spark projects and how that would flow out to state agencies. I'm not, actually, I may have to ask the secretary. I'm a little behind the curve on what's been asked for, but I'm not aware of a current request for staffing funding through the Spark process. There's some other workforce-related items that are more statewide oriented and behavioral health oriented, but nothing specific for the state hospitals.
So to follow up to that, so such as a 50 hospital bed that could be in another location?
That's in the
Be
governor's
eligible?
budget as state general fund appropriation to KDADS.
Well, you said it's out of the state general funds, but I'm just saying there's one-time money out there. And I know a region that needs some beds, so I'm just trying to understand why, I mean, is that a possibility to be applying for those dollars?
I think it is. In our discussions with the governor's office and in putting the budget together towards her recommendation, she wanted to indicate that this was a direction that she's wanted us to pursue, kind of separate of Spark funding. So I think that's why the choice is in her budget to use general fund money for that
That
50
we
bed.
could eventually push for. And I don't know what's the final day to apply for Spark money. Maybe we're already too
We can
far
get that
behind.
for you unless the secretary.
There she goes.
I might just add one, Laura Howard, Secretary of KDADS, one related piece to that would be with the Spark advisory committees that have just gotten started. One of those advisory committees is focused on education and behavioral health. And so some of the issues I anticipate that group will look at will be issues around capacity building that could, overlap a bit with what you were talking about, Madam Chair. So I think that, that work is just beginning. Agencies, through that process, we have the ability as an agency to provide some ideas, as does the public. And that process has just now kicked off. Those groups just met for the first time. And I think the next 2 months will be critical in that process. So I think one of your colleagues is the chair of that, and then Robin Chadwick's actually the vice chair of that advisory committee.
Thank you.
And it's just as a reminder as well, ARPA did pay for the the first part of the 24/7 pay plan, with state general fund being used in the out year.
Yep.
Thank you.
Thank you. Any other questions? All right, thank you. We will move on. And Michelle Ponce, Associate Director, Association of Community Mental Health Center of Kansas, in person. Hi, welcome. I think we have everybody in person. I don't see WebEx at all. All right, very good.
Good afternoon, Madam Chair and members of the committee. I am Michelle Ponce, the Associate Director with the Association of Community Mental Health Centers. We represent all 26 licensed community mental health centers across the state. So thank you for the opportunity to provide testimony today regarding the state mental health hospitals. Our community mental health centers have a long-established partnership working with the state hospitals, including acting as the statutorily designated gatekeepers for admission, as well as working closely with hospital staff for discharge planning when a patient has been stabilized and is ready to return to a community setting. Since the moratorium at Osawatomie was imposed in 2015, that hospital unfortunately has been operating with a waiting list. In fact, even prior to the moratorium, the hospital was often operating at maximum capacity. Then last year, Larner State Hospital also began operating with a waiting list. The COVID-19 pandemic made things even worse, as the hospitals had to further reduce available beds in order to designate quarantine units and operate through the impact of reduced workforce at times due to COVID infections. This limited capacity for inpatient services has been a strain on the system. When a bed is not available for individuals in need, they risk decompensating further, and the local community mental health center may be responsible for identifying a safe environment until a bed becomes available. Unfortunately, even when an individual is ordered to be involuntarily committed to a state hospital, they may end up waiting in jails or emergency departments. Recently, KDADS announced their plans to lift the moratorium on admissions at Osawatomie through opening additional units on that campus and implementation of the state institutional alternative program. We applaud and support these efforts. However, inpatient capacity continues to be strained and waiting lists continue. There are currently 6 private hospitals accepting admissions through the state institutional alternative program. However, currently all of those hospitals are located in central and eastern Kansas, making them a difficult option for patients and families from western Kansas who must travel long distances in order to maintain contact and foster the relationships that are vital to the patient's success within the community upon discharge. We support these efforts to increase capacity, but realize additional strategies are also needed. 2 of those strategies, supported by both the Mental Health Modernization and Reform Committee, as well as in the governor's budget, are increasing the number of regional beds, those 50 additional regional beds that Deputy Secretary Bruner mentioned, as well as an additional 10 million SGF to fund crisis intervention centers, and we support these recommendations. Currently, a number of community mental health centers operate crisis stabilization centers, which do allow for voluntary admission for short-term stabilization services. They've been planning for several years to implement crisis intervention centers, which would allow for serving involuntary admissions and expand the array of services currently provided through crisis stabilization centers, increasing the capacity of our community mental health centers to divert state hospital admissions and further alleviate the strain on the state mental health hospitals. However, we are still awaiting promulgation of the regulations necessary to operate this level of service, and we urge the state to finalize those regulations so that these programs can be implemented. We appreciate the opportunity to appear before you today, and I'd be happy to answer any questions at the appropriate time.
Thank you, Michelle. Of your, what, is it 26?
Yes.
Yeah. How many have the ability to do that intake assessment of the facilities, not 10 are at one and 2 are at another?
The intake for state hospital?
What do you call it? Evaluation.
The mobile competency and restoration services. So that is certainly an initiative that we have been working with KDADS on. They have shared some of their initial plans for that, and we support reducing the number of individuals awaiting those services. However, there are some unknowns related to workforce capacity and training. I can't give you a solid number of how many community mental health centers currently have that capacity. We're confident that some do, but certainly others do not. So we'll be working to increase that capacity in out years. Also hoping that through implementation of the CCBHC model with some additional resources that can help with the workforce issues.
And I don't need that answer tomorrow or next week, but as you develop that and learn more about the 26 and their capability, could you just
Absolutely.
get back with me and then we can?
Yep, we absolutely can do that. That's an ongoing conversation, and we'll gather that information for you.
Thank you.
Thank you.
Questions for Michelle, anybody? I think we're good. All right. I see that I only have one more left. And we cannot finish this hearing without Amy Campbell, Kansas Mental Health Coalition. Welcome.
Thank you, Madam Chair. Amy Campbell, Kansas Mental Health Coalition. This is my testimony. You all are veterans on this issue, so I'm not going to go into all my background in detail here. You can see on the first page that we support all of the governor's budget recommendations. I would like to call out the salary increases. Please do not dive into that either or question of either these salary increases or the 5% global increase. They are both needed for this particular group of state employees. Number 2 talks about the new unit that has been worked on. It's been a slow process, but getting those new beds opened at Osawatomie has been, is absolutely crucial, and we are 100% behind that effort and urge you to fully support that initiative. One piece that's not on my testimony here, but I would call to your attention is that there was the question in Larned, they had asked for $1.4 million and 17 FTE for the PSP at Larned to restore the capacity that had been reduced there. We would call that to your attention, and please delve into that a little deeper. The governor did not support it, but we think that's very important, and you know how important that capacity is at Larned. I understand that they do have staffing issues, but if we could look into that a little bit more. The social detox program, we are behind 100%, and all of the supplemental funding that has been included in the governor's budget is very important. Yesterday, I think you talked about Parsons State Hospital and Training Center and their Behavioral Crisis Stabilization Unit. I'm just calling back to that to say that we really support that happening there as well. Competency evaluation, you've gone into in great detail, fully supportive. I think that's going to be a long process, Madam Chair, in getting capacity out there to help to do these things outside of the Larned campus. But getting started now and putting that money behind it should help. And then, of course, we support the additional regional beds and the pieces that you'll be seeing when you get to the KDAD's budget about crisis stabilization, the crisis intervention centers, and the continued public-private partnerships for the state institution alternative beds that KDAD's contracts for. With that, I'd be happy to take questions.
Thank you, Amy. Questions for Amy? All right. Thank you for being here and offering this information.
I'm always happy to visit with anybody about this issue.
No, we know you're passionate. Is there anyone else here to speak today on this budget? Matthew, what's our next step? Okay, just a sec. Recommendations tomorrow, so deliberations tomorrow. At what time? 10:30? Okay. Senator Petty?
Thank you. I noticed on the number of employees leaving by department, what is an MHDDT?
Senator Petty, thank you for that question, because I didn't call out that we handed this out before, and I meant to do that. MHDD is a mental health disability technician. That's the frontline entry-level direct care position.
So that I'm going to just make this assumption that this must be fairly low on the pay schedule because they're just coming in and going out.
They're the so today, after the executive directive, their starting wage is $16.16 an hour. Before that, it was in the $12.34 at Parsons and KNI and at Osawatomie. 14. It was a little higher at Osawatomie.
Is 16 your lowest pay on folks that come in? No? For direct care. That's the low pay for direct care. Okay.
You referred to that yesterday, didn't you? I think you mentioned about that.
Okay. All right. Did you have a question? Okay.
So that handout was in responding to Senator Solentrop's question about turnover, and we had this data from some work we did over the summer, so I'm happy to talk about it, but I apologize for not calling out that we
Pretty interesting.
passed it out before.
Okay. Any other questions? Seeing none, we're adjourned. Thank you all for being here.
Thank you.